Good afternoon and welcome to a webinar on 2 renewed trans-NIH funding announcements for developing and testing health-enhancing physical activity interventions. Next slide. My name is Stephanie George. I'm an epidemiologist here at the Office of Disease Prevention at NIH. I'm joined today by program officers across 7 institutes at NIH. They're represented here and their contact information is within the text of the actual program announcements. If you have questions for staff during the webinar, please submit your questions via WebEx in the Q&A button on the top right of your screen. Or you can email questions to prevention@mail.nih.gov, or you can reach us on Twitter using the hashtag NIHPAR. These funding announcements are 2 types. One is an R01 application related to the testing of multi-level interventions for increasing physical activity. All of the institutes that you see on the first page with all of the faces are participating in this announcement. The second is for R21, R33 applications related to the development of multi-level interventions for increasing physical activity. And here you see the institutes who are participating in this announcement. The purpose of these funding announcements are to fund highly innovative and promising research designed to develop and test multi-level interventions for increasing physical activity. Specifically, NIH has interest in proposals where interventions act on at least 2 levels of the socioecologic model, which we'll walk you through in a few slides forward, have potential for scaling and sustainability for broad use, which we'll also talk about further, and interventions that are conducted in populations at high risk for sedentary behavior. Now I'm going to pass the baton over to my colleague, Lene Mudd at the National Center for Complementary and Integrative Health.
Hello. So we've been trying to move the needle on physical activity behavior for a while with limited success. However, some accumulating literature suggests that multi-level interventions may be more impactful, which is really the impetus behind these FOAs. We are encouraging applicants to use the socioecological model for conceptualizing their multi-level interventions throughout these 2 FOAs. Next slide. For those who may be unfamiliar, the socioecological model is pictured here on the bottom right. And you can see it spans many levels from the individual level through the organizational level and even up to the public policy level. There are many ways for an intervention to qualify as multi-level as long as there are intervention components that are active at least 2 separate levels. So to make this more clear, we're going to walk through a couple of examples. So first, let's pose a situation that investigators might come to a program officer with questions about for one of these FOAs. So this investigator is proposing to randomize individuals to participate in a group-based exercise class or a health education class at a community center. Now, you might at first think that this is a multi-level intervention because it is being conducted at a community center. However, in reality, there's only intervention components active at 1 level. Hit the next button. So although the sessions are delivered in a community center setting, there's no intervention components to change that setting, and thus it is only targeted at the social level or interpersonal level with a group-based exercise class. Now suppose we change the situation. So now we're still randomizing individuals to participate in a group-based exercise class or health education class at a community center. But now exercise participants are also going to receive personal goal setting and feedback, and the interventionists are going to help community centers initiate or strengthen joint use agreements for their facilities. Now this becomes a multi-level intervention with active components at the intrapersonal level with the group exercise class, the interpersonal level with the personalized feedback and goal setting, and the organizational level with the joint use agreement. Now, one thing that's really important within these FOAs is to clearly convey your intervention to the reviewers as well as program staff. And so we really recommend conceptualizing your intervention and using a figure or a table to depict active intervention components and measures at different levels of the socio-ecological model. So this figure might be used to depict the components from the previous example. You could also, in addition, provide a figure of the theoretical model of why these intervention components are likely to work together to enhance physical activity. The key is really to provide in text as well as graphics and tables clearly stated active components at 2 or more levels with measures to assess these components at each of the levels and provide justification for how the components will work together to improve physical activity in the target population. You can assess physical activity at 1 level, or you could provide physical activity assessments at each of these levels as well. All right, so another question we often get as program officers when applicants are thinking about applying is, which of these FOAs is right for my research question? Should I be coming into the R01 or the R21 and R33? So just to differentiate these two, very simply stated, the R01 is going to help investigators answer the question, does this work? Whereas the R21, R33 will help investigators answer the question of, can I do this? So to break this down, the R01 should be powered to test efficacy for increasing physical activity. It should also collect data that is relevant for future implementation to see how these could be scaled up. And in order to propose an R01, you should be supported by preliminary feasibility data, which you could use the R21, R33 to obtain. So the R21, R33 is specifically focused on assessing feasibility and acceptability of the approach. And investigators should not be proposing to look at preliminary efficacy within the R21, R33, as these effect size estimates can be quite misleading when you're not appropriately powered. Importantly, the R21, R33 application does need to include clear descriptions and aims for both phases of the research. And this includes everything from the aims, the research plan, and the budget and budget justification, as well as clear milestones that you need to meet after the R21 phase in order to transition to the R33. So a further question that investigators who are interested in the R21, R33 may have is, what scope of research is appropriate for each of these phases? And so there are several examples of different types of research that might be conducted in each phase within the FOA itself. And here are a few to highlight. So at the R21 phase, you might be interested in conducting a single site feasibility randomized control trial of a multi-level intervention, or perhaps separate feasibility studies for each intervention component that you're proposing at different levels of the socio-ecological model, or qualitative and mixed method approaches to determine acceptability and refine components. If you are successful with the R21 phase and meet milestones in the R33 phase, you might propose to conduct a larger scale or a multi-site feasibility randomized control trial of the multi-level intervention. Or look at the effect of the multi-level intervention on hypothesized mediators of physical activity change. Importantly, you still do not need to be powered to detect change in physical activity in the R33 phase. That would be appropriate within the R01. However, the R33 can give valuable information to optimize your multi-level intervention in preparation for the R01.
And now we'll hear from all of our NIH program officers who are program contacts for these funding announcements about scientific priorities. First, we'll hear from Renee Mudd at NCCIH.
Hello again. So the National Center for Complementary and Integrative Health is particularly interested in applications proposing to incorporate a mind-body approach as part of their intervention for promoting physical activity. So a mind-body approach might include things such as mindfulness or meditation or Tai Chi or yoga or other complementary approaches. Importantly, we will not support research proposing to test efficacy or effectiveness of clinical outcomes such as pain or hypertension or obesity within these FOAs. So we do want you squarely focused on physical activity.
Good afternoon. This is Frank Perna from the National Cancer Institute. So NCI is interested in supporting applications that target either moderate to rigorous physical activity, those seeking to increase light intensity physical activity, or reduce sedentary time if distinct. So you can focus on either spectrum, physical activity spectrum. NCI is also interested in applications that propose to sample cancer survivor groups, and especially pediatric cancer survivors. We have a sore need for research in that area, as well as those without a cancer history. And lastly, NCI is interested in applications that will collect implementation data of interventions testing efficacy or effectiveness across multiple project sites.
And next we'll hear from Dr. Lyndon Joseph at the National Institute for Aging.
As you can see, the mission of NIH is to improve the health and well-being of all individuals. And specifically what we're interested in is interventions that's used in this multi-level program to promote physical activity and I should have put here also to reduce sedentary behavior. So we're interested in this from the perspective of improving physical function. Not only physical function, but also looking at how to prevent or reduce the burden of age-related diseases such as diabetes or hypertension or hyperlipidemia. And we're also interested in studies that's looking at health disparities and how physical activity improve the health of people in diverse populations or in rural areas. So if you can look at health disparities, physical function, and chronic metabolic conditions as is affected by physical activity and reduces sedentary behavior, we would definitely interested in those type of applications.
Thank you, Dr. Joseph. Next, we'll hear from Dr. Mike Hilton, who's stepping in for Beverly Ruffin at NIAAA. Dr. Hilton. Great. I will read Mike Hilton's slides for him. So NIAAA is specifically interested in research or prevention strategies to address alcohol use in the context of physical activity. NIAAA, for both program announcements, also has interest in feasibility and pilot studies that will contribute to expanding the knowledge base of associations between physical activity and alcohol use. They strongly encourage research on both the individual and environmental physical activity strategies. So, for example, prevention intervention studies that incorporate both strategies to reduce risky behavior. And last, they have interest in understanding mechanisms behind associations of physical activity and alcohol use. Next, we'll hear from Dr. Ralph Mitkins.
Okay, the Eunice Kennedy Shriver National Institute of Child Health and Human Development supports a variety of populations, but within the context of this program announcement, it's only restricted to research through the National Center for Medical Rehabilitation Research, which supports rehabilitation research across the lifespan and aims to ensure the health, productivity, independence, and well-being of people with physical disabilities. And in this context, I should also mention that you heard that we're using both the R01 and the R21, R33, but NICHD applications and rehabilitation will only be supporting research through the R01 part of this. And this can include topics, as we list on the right, issues such as participation, quality of life, prevention of secondary consequences, contraindications, limitations, barriers, needs, motivation, strategy to sustain, and the effect of active fitness on healthy outcomes in people with disabilities. Thank you.
Next, we'll hear from Dr. Acklin at NIDA, today represented by Ann Anderson. Ann.
I'm Ann Anderson. I'm standing in for my colleague, Dr. Acklin, at NIDA. NIDA is interested specifically in behavior change related to substance use. So looking for decreases in the amount or frequency of substance use or extending abstinence. The substances could be several, that are in our portfolio. Of course, opioids, we have funding now available for opioids, but also smoking, marijuana, and still methamphetamine and cocaine. Those are the substances that we work on. The last bullet you'll see there, it says we're also interested in behavioral strategies to promote medication adherence. So again, using the example of opioid use disorder treatment, the medications for that, the methadone or the buprenorphine, if physical activity can be used to increase the adherence to those medications, that's a good thing, and we'd like to see that be demonstrated. So questions can be addressed to Will, whose email is up in the upper right corner there, and please do.
Great, thank you very much. And last we'll hear from Dr. Nancy Jones at NIMHD. Nancy.
Good afternoon. Again, I'm Nancy Jones at the National Institute on Minority Health and Health Disparities. And so one first requirement is that any applications must address one or more of the health disparity populations, including the racial, ethnic minorities, as well as socioeconomically disadvantaged populations, underserved rural or sexual gender minorities. And specific interests that we have are interventions that are designed for settings where we know our health disparities populations either live, work, play, or receive health care. We're also interested in interventions that address neighborhood social environment, structural barriers, or facilitators, and interested in assessing unintended policy considerations after an intervention. And lastly, we're also interested in interventions that use novel behavior change strategies that target decision-making processes under conditions of high stress. We would also refer you to our NIMHD research framework that lays out some of the levels and domains that we think are important for addressing minority health and health disparities. Thank you. Next.
Great. Thank you to all the program officers for helping us understand a little bit more about your scientific priorities at your different ICs. So a question we often get as program officers here at NIH is, what if my population, intervention components, and/or secondary outcomes don't match well with any of the institutes or centers' priorities that are participating in this announcement? So just so you know, your application will get assigned to an IC based on the priorities that are stated in these funding announcements. At the end of this presentation, we lead you to those links so you can look at them in more depth. These slides, I should mention, are also going to be available after this webinar, so you can reconsult those scientific priority slides as well. Applicants are highly encouraged to discuss potential research aims with contact program officials at participating ICs. Applications that are not well aligned with the programmatic priorities are unlikely to get funded, even if they are accepted for review and score well. And program officers can often help applicants identify alternative funding announcements. If it's determined that your goals and/or any of the things above, like your population intervention components or outcomes, don't really align and fit well within these announcements, like Lene was talking to us before about, so they can help you identify other potential funding announcements for your work. We also get this question quite often: can NIH offices hold grants? Importantly, NIH offices, like the Office of Disease Prevention, do not manage grants. So the grant will be assigned to and, if successful, awarded by one of the participating institutes and centers for these announcements. If your application scores well and is being considered for funding, your assigned program officer can initiate a co-funding request to the Office of Disease Prevention. This is not something that's handled by the grantee. So applicants are highly encouraged, again, to discuss their research aims with the contact program officers at participating ICs. We link here to the 2 funding announcements that we've discussed today in this webinar for the renewed announcements. We also provide a link for you on frequently asked questions, which includes some of the ones that we've covered today and others which we've handled at more length in this document. Now we'll open up the floor for questions. We've received quite a number from those of you who are signed into this webinar. And we'll also ask you now, if after the webinar you have some questions you'd like to submit, please submit them via WebEx in the Q&A function on the top to prevention@mail.nih.gov or on Twitter using the hashtag NIHPAR. So I'll serve as the moderator for some of these questions, and then I will turn out the questions to our program officers here to handle. Oops, I'll leave that screen up for you. So the first question that's come in, I'm going to direct to Dr. Lene Mudd at NCCIH. Must a fully developed budget and budget justification be provided for both the R21 and R33 portions of the proposal?
Yes. So if you are applying to the R21, R33 mechanism, it's very important that you fully describe both phases in your application and provide all needed information about both phases. This is a common mistake that we see, and unfortunately, those applications that don't have a whole lot of information about their R33 phase are often triaged in review.
Next question. What is your interest in funding a family-based intervention designed for weight reduction? I'm going to send that question over to Dr. Frank Perna at NCI.
Well, as the FOA states, the primary outcome should be physical activity related, so it can incorporate obesity, but it has to be first and foremost targeting activity level. Family-based interventions are completely acceptable for us. In fact, we spur even certain kinds of analyses, dyadic analyses. We have up on our website information on how to conduct those analyses, and we're associated with our FLASHY, which is a cross-sectional survey that they would be ideal for interventional experimental design as well. And lastly, while NCI is always interested in research related to cancer survivorship, that would include a parent or child, a family member with cancer, we also fund research at every level of the cancer continuum. So we would certainly be interested in family-based applications that don't necessarily contain a cancer survivor.
Great, thank you, Frank. Our next question is, are you interested in funding a program that involves physical activity and healthy eating together? I'm going to send that question over to Dr. Ralph Nissen at NICHD.
Okay, well, much like the previous question, we're interested in whatever is appropriate to support the social ecological context of your study. So there certainly is a linkage for diet, nutrition, family, broader issues like that. But your primary goal, your primary outcome has to be on physical activity. But we welcome something that has the ecological validity and including the appropriate contextual issues, as long as your primary focus is on physical activity.
Great, thank you, Ralph. Next question. I will submit an R21, R33 application for physical activity promotion among minority and low-income children ages 10 to 13. Both NIMHD and NICHD only participate in the R01 mechanism. Does that mean that I can only list NCI as the institute if I use the R21, R33? So let me send that first over to Nancy Jones at NIMHD. Nancy, can you take this question?
So we would not receive an R21 and R33. So the piece of who would be willing would have to align with what those specific, there are other ICs that have an R21, R33, but you would have to align it with their specific interests.
Great, thank you, Nancy, and I'd like to piggyback that on to Frank. Frank, can you provide some context?
Yes, we get a lot of applications at NCI because we do participate in those mechanisms. So while the kind of guts of the study has to be physical activity related, would probably be common, the study still has to be framed within the cancer control perspective in terms of its relevance for us. So you still have to make the case for that for us to accept it. Often, I wouldn't say that's necessarily a very high bar to clear, but you have to put some thought into that application and not just, oh, it's not going to go there, I'm going to basically just submit that. In fact, sometimes I'll see an application like that, and I might even just do a word search for cancer, and like it doesn't even appear sometimes in an application.
Right.
So.
And Ralph.
Yeah, certainly the Eunice Kennedy Shriver National Institute of Child Health and Human Development would love to talk about a study to promote activity among kids, and particularly the nuances of doing it within a minority population. However, in the context of this announcement, our institute has had to limit resources and coverage, and we're just not funding that mechanism. So you'd be out of luck in that particular context, but we'd certainly welcome a broader discussion for a regular good old investigator-initiated application.
Great. Thank you. We're going to move on to the next question. For the criterion related to the populations being at high risk for sedentary behavior, are you thinking here about inactivity, low physical activity levels, or sedentary behavior specifically? Thanks for any clarification you can provide. Frank, can I toss that over to you?
Sure. As we've stated in our interest in terms of fostering research at each kind of level of physical activity, the rationale has to be clear for both, and this is somewhat in line with the physical activity guidelines in terms of having separate guidelines for moderate to vigorous physical activity, sedentary behavior, as well as increasing light activity. And so while they're typically, you're going to see an inverse relationship between sedentary behavior and light activity, that's not always the case, and sometimes we'll see, particularly innovative designs that are targeting one of those aspects, but not necessarily the other.
Great answers. Next, Lene, I'm going to send these questions over to you at NCCIH. There's two questions combined, and I think you could answer them probably together. First, would you mind clarifying the information that the R21 should not state that a preliminary efficacy is being tested? And the second piece is, R33 should not assess efficacy on physical activity, but can assess efficacy on the mediators?
Sure. So this kind of gets to the uses and misuses of pilot studies, to which there's a growing literature, and I would say there's been really a shift in thought in terms of what a pilot study is good for. So, probably 10 years ago, the idea was you do a pilot study to get an effect size to power your larger study. And now, many statisticians have been publishing that that's actually not a good idea because effect sizes from small-scale, underpowered studies are really unstable. And so oftentimes you see just huge confidence intervals, and you really don't know whether you're underestimating an effect size or overestimating an effect size when you have such a large confidence interval. And so instead, we really are pushing investigators across the board in many fields to use pilot studies as a chance to test feasibility and acceptability. Can you recruit individuals? Can you get them to agree to be randomized? Can you successfully randomize? Will they adhere to the intervention that you propose to do? Can you collect the data you want to collect? All of those types of things are really important information building blocks, or what we call them, in terms of understanding, can you actually do what you want to do? And once you figure that out, you can propose a fully powered study to determine whether it actually works. And to power that study, we really recommend using the concept of minimal clinically significant difference, as opposed to using an unstable effect size from an underpowered pilot study. The R21 and R33 phases both really don't provide the amount of support or years that you need to conduct a powered efficacy study. And so we have really rescoped the R21, R33 FOA to very much focus on feasibility and acceptability outcomes as opposed to, you know, underpowered looks at efficacy for the physical activity outcome. Now, I did say that the R33 could be powered to look at mediators of physical activity change. Oftentimes, mechanistic outcomes or mediator outcomes have a smaller range of variability, and it's easier to then power a small scale study to be able to adequately assess whether that mediator is changing or not. Great, but that's something to talk with statisticians and your program officers about.
And Frank.
Yeah, I was going to add to that clinical significance as well as not only, in fact, I guess, emphasized in that mechanism rather than only statistical significance, and developing your intervention so that it's potent enough, basically, so when it is fully powered, that it's optimized, and specifically use that term. There's also a publication, the Orbit model for developing behavioral interventions. That was a kind of trans NIH intramural extramural investigator publication that kind of describes that research process, that those early phase studies and what they're trying to accomplish, and it's Renee laid out, and what they can't necessarily accomplish.
Great. This is a piggyback to the question about feasibility data. Do you need preliminary data on feasibility of all of the components of the multi-level intervention to come in with an R01 application? I'll get this one to Ralph.
Okay, so I would say feasibility and pilot data actually occurs at a lot of different levels. There might be feasibility to show that your theory, your hypothesis is correct. There might be feasibility to show that you understand your patient population. There might be feasibility to show that they'll put up with the intervention that you're promoting. And so the feasibility would depend a lot on what you're proposing and how much it might run counter or unexpected to prevailing views. So the beauty's in the eyes of the beholder as far as that goes.
Feasibility could be demonstrated at one level, but not necessarily across settings, too. So there's not only the individuals that you're targeting, but particularly if you're going to implement across different sites, is it feasible across those sites? That would be particularly useful information to have.
Great. Dr. Nitkins, can you please provide examples of disabilities? Is there an interest in children with disabilities as participants in these funding announcements?
Yes. Disabilities has a lot of different meanings, but in the context of this, the National Center for Medical Rehabilitation tends to focus on physical disabilities and secondary issues. Certainly focusing on children would be more than welcome because you have a lot of opportunity for change and interacting with the family and contextual issues. That would all be appropriate and fair game, but the context here for us would be more physical disabilities as opposed to our traditional interest in, say, intellectual and development and other developmental disabilities.
Great. Next question. Would mental health be considered a focus area for this type of a study? Frank.
So at NCI, if physical activity was the outcome and a mental health or affective component would be in there, it would have to be in a cancer survivorship group because we support studies there. And that's one area where we would diverge from other studies of the general population. So if your secondary outcomes are more effective, they would be less likely to come.
I will say that NCCIH is population agnostic, meaning that we will accept applications across a broad range of populations as long as the intervention itself includes some kind of mind-body component within the multi-level intervention. So if you wanted to study how to increase physical activity among a depressed population or an anxious population, certainly NCCIH could be interested in that as long as a complementary mind-body approach was included.
Yeah.
And I could add that promoting mental health could certainly be part of the mechanism of improving behaviors and improving physical function. So, for example, depression would probably be the inverse of supporting activity. So I think that would be fair game, but your focus has to really be on physical activity, not curing mental health per se.
Right. And I would add also to refer you back to the slide at the very end of the deck about what if my population intervention components and outcomes might not be on paper look like a perfect match for one of these ICs. You can reach out to the program officers and have conversations like that they've just shared with you to learn more if that would fit. The next question. In the program announcement, it asks for a graphic logic model. Is this referring to the socioecological model?
Yes, we strongly encourage you to include a figure like the one that was included in the slides, although certainly you might be more creative than I was at creating that figure, but a logic model to show not only the different levels that your intervention is targeting, but also it would be helpful to include that theoretical perspective of how you anticipate these intervention components working together to improve physical activity in your population.
Great. Are applications reviewed by an ad hoc panel or a standing study section?
Well, historically they've been reviewed by special emphasis panel, which is convened, although there's a lot of continuity among the members of that panel.
What is the age limit for a proposal to be considered by NIA? Dr. Linden, will you take this question?
Hi. When you say age limit, are you talking about low or upper? So basically,
Why don't you
right.
speak to both?
So for NIA, the majority of our studies deal with people 50 and older, but we are the National Institute on Aging. So we do take studies that look at things across the lifespan. If you're looking at that particular outcome, you know, how does an intervention affect a 30 to 40-year-old versus a 50 to 60-year-old versus a 70 to 80-year-old. If you're looking at that perspective and you're doing it across the lifespan, NIA will take that. But if you're just looking at an older individual and how it affects, you know, mobility or walking speed or diabetes, then you know, 50 and over is usually a good age to start from.
Thank you. Can the R21, R33 mechanism be used to fund data collection designed to elucidate mechanisms for engagement in PA, in physical activity? Ultimately, these data would inform the development of an intervention, but may not occur in the life of the current grant. It sounds like this question is specific about could the R21, R33 fund data collection about mechanisms for engaging in physical activity?
I would see that as probably meeting the bar for acceptance, but may be questioned in terms of, you know, how is that going to lead to optimization of an intervention?
Yeah, I think it would depend on how it's framed a bit more. So that one might be helpful to reach out to a particular program officer with your draft-specific aims to get more detailed feedback.
Great. A clarification question regarding the multi-level approach. The focus is on understanding the effects of the multi-level intervention rather than, say, investigating the interest in a single versus a multi-level approach, or are both supported? Lynette, you want to take that?
These FOAs are really geared towards understanding the effects of a multi-level intervention. Comparing a multi-level to a single level would be of less interest.
These funding announcements state that the primary outcome must be physical activity. In the presentation, it was suggested that the R21, R33 should not be powered to show change in physical activity, but should look at behavioral mediators. Can you clarify this? I think Lene talked about this in a previous question, but maybe just give a short answer to that, Lene.
Yeah, I think that the goal of the R21, R33 is really on developing an intervention that can be tested in an R01 for efficacy on actually changing physical activity.
Right. And I think the optimization part too, that the intervention is potent enough to hit the target of activity, not just drive a statistically significant change, that those early phase studies are necessary to do that, even though they're not going to demonstrate efficacy to traditionally think of it.
Does any of the funding mechanisms support testing the feasibility of new methods of physical activity data collection in the community setting? Also, Mr. Frank.
I think methodological improvement would be well received. However, you still have to meet the other criteria, so it can't only be a methodological grant.
I would also say that we do have other funding opportunities available specifically for validating new measures of physical activity, and that might be a better fit for that research.
Yeah, I would add that I think in the context of this RFA, I mean, this program announcement, it would be maybe a lower priority unless you can really make the case that the information you're going after is central to promoting activity and a unique hypothesis, a unique approach. But if it's just promoting your own approaches, it would probably have less impact.
Great. This is another question on mediation analysis. Dr. Mudd, mediator analysis is proposed as one of the R21, R33 aims. Should we power for the effects on the mediator variables, the impact of the proposed intervention on physical activity? These are supposed to be in order there, or the impact on physical activity. Would mediation aims be more appropriate for the R21 or R33 phase?
I think that likely any kind of mediator analysis is more appropriate for the R33 phase, which has expanded funding and time available to you. The R21 phase really is about the small-scale feasibility work to transition to the R33 phase. And if you are going to propose looking at those mediators, you should be powered to look at them. Again, you should not be proposing to do underpowered analyses that are not supported.
I saw in an earlier slide that promotion of light physical activity would be an applicable outcome for the R01 FOA. Did I understand that correctly, or does the outcome need to be about meeting moderate to vigorous activity guidelines? Frank, do you want to take this?
We would accept applications that target light activity, as well as moderate to vigorous physical activity, and all applications will have to have a justification for why you're targeting that level and why that is important to the secondary outcome.
Yes, and I would add that it goes back to the issue of clinical significance. So if for that particular patient population, you can make a case that light activity will lead to healthy outcomes and some sort of catalytic effect, especially in our case, in the context of people with physical disabilities, you can imagine how it will bring them to a new plateau, a new level of engagement. That would be fair game. But light activity itself may be viewed in another context as just being something that lacks real impact for that patient population.
Thanks. This next question is for Frank. My target population is Black breast cancer survivors and expanding implementing care plan recommendations for physical activity. I'm also interested in cardiovascular health in this population. I'll add in, does this fit with NCI's priorities?
Yes.
Great.
Very much so.
Thank you. Does NCCIH require preliminary data for the mindfulness components of the intervention?
So preliminary data are not required for the R21, R33 phase. If you are applying to an R01 phase, then we would require preliminary data that you are successfully able to implement the mindfulness component.
Thank you. Can you address the multi-level intervention aspect of the application application? I'll refer who asked that question back to our slides. We're going to move on to the next question. To what extent are the participating institutes interested in the role of the built environment as a primary physical activity intervention strategy among low-income children, adults, and people with disabilities, where individual physical activity levels are often measured? I'll give that to Ralph.
Yeah, I mean, certainly in the case of people with disabilities, the built environment could actually be a barrier or, in other contexts, of support. So that would certainly be a very valid consideration if your primary focus is promoting activity.
Frank, do you have anything to add to there?
We funded a couple applications that are considering that already. So if you look up the program announcement and NIH reporter, you can see a list of some of the ones we've supported that cover that area.
Great. Thank
and
you.
This is Nancy Jones at NIMHD. The low-income aspect we would be interested in, but the types of interventions for the built, we would also like them to be sustainable in low resource settings.
Great, thank you. We had a previous question about asking questions about what the budget looks like, what are the particular specifics, and I'm going to refer you to the actual instructions in the SF 424 in the application guide for specific budget questions that we're not able to answer specifically on the webinar right now. Next question. Are you strictly looking at physical activity as exercise? Can other activities outside of exercises be considered as physical activity for the elderly? This is for Lyndon Joseph.
So, interesting question. So I also mentioned that we are interested in reducing sedentary behavior. So the way I look at it is that if you can increase their physical activity through changing behavior patterns and monitor their physical activity to see if they'll increase it at the end of the intervention, that could work. But it depends on how you frame the discussion, how you frame your premise, okay? So the majority of them would, yeah, we're going to try to increase your physical activity by having you do some sort of exercise intervention. But there's also behavioral component that people that we at NIH are also interested in as well. What prevents people from actually being active? What prevents them from reducing the sedentary behavior? What makes them want to sit down for 9 hours a day and do nothing? So depending on how you frame it, we'll definitely take a look at the AIMS page and see whether or not you frame it in an appropriate way that fits the mission of NIA.
Great. Thank you, Lyndon. If you can stay on, I have two other questions for you. Is NIA interested in interventions to increase physical activity for the secondary outcomes of promoting cognitive function and brain health?
The easy answer is yes, but as a couple of the program officers said earlier on, the primary goal is to increase physical activity. But if your secondary goal is to increase cognitive health, we will take those secondary outcome measures.
Great. And last question for you, Lyndon. Is NIA interested in receiving a proposal targeting older adults living in rural areas?
Yes, and yes. One of the bullets I have was looking at health disparities, and you know, that's a population that really a lot of people don't look at because of access. And so if you can come up with some sort of interventions that can help increase physical activity in rural areas, whether or not it's through telehealth or some sort of technological advance, we would definitely be interested in those type of studies, yes.
NCI would also be interested. In fact, initiatives related to rural health that we're pushing now, so if it wouldn't be appropriate for this program announcement that we're discussing today, there are other ones that NCI has as well.
Great. Can the R21, oh, sorry, is that Nancy?
I was going to say this is also Nancy Jones at NIMHD, and so underserved rural populations, our health disparities population would also fit at NIMHD. Thanks.
Great, thank you. The next question, can the R21, R33 mechanism be used to refine, not develop a new intervention or program, an existing intervention to maximize impact and enhance scalability?
Yes.
Yes.
Great. Next question. If you are applying to the R21, R33 and it is a new team that's never worked together before, would you recommend that they first establish themselves as a team, for example, publish together prior to applying? Lene.
I certainly think that that could help you be more competitive. Otherwise, you're going to face a tough bar to justify that you will be able to work together as a team.
And it would depend on the complexity of your intervention, the amount of administrative connections that you would need. But it always helps to show that you've worked together and you're committed to the same goals.
I would just add to that, like in some ways too, you can demonstrate that you've worked together, particularly if there are a research component and then say a clinical component where you may not have published with people, but you've interacted with that entity or organization. That's also a way of demonstrating collaborative work.
Great. For the definition of high risk for physical activity, could that include women specifically who are typically less likely to benefit from physical activity interventions and more likely to experience risk from chronic health conditions? I think I would refer the person who submitted that question specifically to the funding announcements themselves to really look at what the priorities are of the institutes involved and the populations that seem of high interest to them, and to contact a program official with your specific aims so we know a little bit more about the study. And we are coming to a close for our webinar here. We have fielded close to about, I think, over 50 questions. So I'm going to give a great thanks to our program officer team here at NIH. Again, you can find their contact information in the program announcements themselves. We encourage you, to develop your applications and talk with us while you're developing them. This webinar, we've also received the question multiple times, can I see this again? And the answer is yes. In the coming weeks, we'll be able to post this on the ODP website, and we'll be able to make that available to all of you. Anyone who registered for this webinar, we have a direct way of contacting you and letting you know when that resource is available. And Ralph.
I just wanted to emphasize that for those of you that may not be that familiar with the NIH and appealing to some of our study sections, I think it's really important that you have a mechanistic hypothesis for what you're doing. So not just that you're showing an effect on your chosen patient population, but you have some idea about why, so people can then build on your study. So it's very important for you to ground this in predictive hypotheses, whether it's psychosocial or physiological or whatever is appropriate.
Great. Thank you very much for joining us today for this webinar on these two renewed funding announcements.
We look forward to seeing your applications.